Hi, my name is Neil Anglin, and today I'm going to talk to you about how to assess a patient with palpitation. So, what do we mean by palpitation? So, patients often present with the sensation of their heart beating, either beating fast, can be slow, can be quite forceful, can sometimes be irregular. Patients are quite anxious about these symptoms as well. So, when assessing a patient, first thing to do is take a history. You want to know how often do the palpitations come on for? Do they come on, are they a sudden onset, or do they gradually come on? And how long do they last for? Are they fast, slow? It's quite a good idea to ask the patient to sort of tap out the palpitation so you know if it's fast, slow, or irregular. Are there any associated features with the palpitation, such as lightheadedness? Anyone ever blacked out or had a syncopal episode with a palpitation? Other features to ask about, do they become short of breath, or is there any chest pain? You also want to know, as part of the history, is there any family history of arrhythmia or unexplained blackouts? If we now have a think about the broad categories of what could be causing the palpitation. So first of all, from a cardiac perspective, we're obviously interested in cardiac arrhythmias, be that a tachyarrhythmia, or sort of fast rhythm problem, bradyarrhythmia, or a slow rhythm problem, or an irregular rhythm. There can also be extracardiac causes, such as high output states, anemia, pregnancy, thyrotoxicosis, fevers. They can all cause increase in your heart rate and a sensation of palpitation. Other cardiac causes include valve lesions, such as mitral regurgitation or aortic regurgitation. The reason that can cause palpitations is because when you've got more blood being pumped out of the heart, it can cause a more forceful sensation in the chest. Certain drugs can cause palpitations, such as alcohol or caffeine and various stimulants. And lastly, anxiety can also cause the symptom of palpitation. So from the history, you need to try and decipher which one of these causes could be causing the symptoms. On examination, there can also be some clues. By just taking a look at the patient, are they cynosed? Could that be a sign of heart failure or lung issues? Are they short of breath? Again, heart failure or lung issues. Are they pale? If someone's very pale, that could signify anemia, which again can cause a tachycardia and therefore the sensation of palpitation. Do they have a fever? Fevers can cause sinus tachycardia or either thyrotoxic. If they've got features of thyrotoxicosis, they could have a sinus tachycardia or even an abnormal heart rhythm such as atrial fibrillation. So on this slide, I just want to really summarize all the different causes of palpitation, splitting into those broad categories. So from an arrhythmia perspective, you could have a bradyarrhythmia, sinus tachycardia, atrial fibrillation or flutter, atrial tachycardia, atrial or ventricular ectopic beats, supraventricular tachycardia, and ventricular tachycardia. From non-arrhythmic causes include septal defects, congestive cardiac failure, congenital heart disease, cardiomyopathy, and valvular heart disease. Extracardiac causes include anemia, electrolyte abnormality, hypoglycemia, fever, hypothyroidism, hypovolemia, pregnancy, or pheochromocytoma. From a drugs perspective, this alcohol can cause the palpitation, as well as caffeine and other stimulant drugs. Sympathomimetic drugs such as beta agonists and things like nicotine can also cause palpitation. And finally, anxiety, depression, as well as panic attacks can cause palpitation. To investigate the causes of palpitation, we can start with simple tests first of all, such as blood tests. Blood tests can reveal certain information. For example, a full blood count. If they're anemic, they'll have a low hemoglobin, which can be a cause of the palpitation. Looking at the urea and electrolytes, specifically the electrolytes, if they're at high or low potassium, abnormal magnesium levels, this may predispose you to certain arrhythmias. Raised inflammatory markers in the full blood count, or CRP, may suggest an infection, which is therefore causing a tachycardia. Abnormal thyroid function tests may suggest thyrotoxicosis. 24-hour urine collection for catecholamines may suggest things like pheochromocytoma. A 12-lead ECG is obviously very useful. If the patient's having palpitation at the time, getting a 12-lead ECG can clinch the diagnosis of whether this is an arrhythmia or not. Often patients, however, present with symptoms of palpitation but not currently experiencing the palpitation at the time. What I do try to say to patients is if they are experiencing palpitation and they're near a medical facility, is to try and get that 12-lead ECG, which will hopefully clinch the diagnosis. However, a 12-lead ECG when someone is not experiencing palpitations may give us some clues of why they are experiencing palpitation. There may be evidence on the 12-lead ECG of cardiac ischemia. There may be clues on the ECG that predispose you to abnormal heart rhythms, such as delta waves or a prolonged QT interval. So prolonged QT interval can predispose you to abnormal heart rhythms that go along with long QT syndrome, which include ventricular tachycardia. Having a delta wave may suggest Wolff-Parkinson-White syndrome, which would predispose you to supraventricular tachycardias. However, as suggested, the majority of patients present without actually having the palpitation at the time. So what would be the definitive diagnosis to look for cardiac arrhythmia? Well, the first thing I would suggest is an ambulatory cardiac monitor. This is useful if you know that the patient is going to experience the palpitation during the period of time of wearing the monitor. So, for example, if they experience the palpitation daily or every few days, then having a 1-week ambulatory cardiac monitor will be very useful in order to try and capture their symptoms while wearing the monitor. If you capture the symptoms while wearing the monitor and they actually do not have an abnormal heart rhythm, then we need to look at other causes of the palpitation. If the symptoms of palpitation are very infrequent, another option is to implant a loop recorder. This is done under local anesthetic, and the battery life of the loop recorder usually lasts for up to 3 years. And therefore, if a patient experiences palpitation during this period of time, we can analyze the loop recorder and see if it's due to a cardiac arrhythmia or not. Some patients complain of palpitation on exertion or when doing sporting activities. Obviously, when someone exerts themselves, your heart rate will speed up, and some people will experience palpitation just simply because they're exercising. However, if patients feel that the palpitation is out of keeping, it's not in keeping with the amount of exercise they're doing, for example, it's going very, very fast heart rhythm, and they're not actually doing too much, then this does warrant further investigation. Another investigation of choice is an exercise test. So patients are put on a treadmill with increasing workload and speed while they're wired up to an ECG. And during the treadmill test, we record an ECG to see if any rhythm abnormalities develop during exercise. If a patient presents with having palpitations, you need to do a quick assessment to find out if they're stable or unstable. So I would always start, when seeing a patient with palpitations, I always start with the ABC approach, check the airway, breathing and circulation to make sure that to see if they're stable or not. So A stands for airway. You'd have a look in the mouth, make sure there's no obstruction there. Breathing, assess their breathing, do an examination of their lungs, check their oxygen saturations, and ensure that their lungs are clear. Next, you want to check their circulation, so assess their blood pressure, pulse and heart rate, see if they're pale, look at the capillary reflex, and obviously if these are stable, then you can then carry on the further investigations. Then if they also point to something that needs treating straight away, for example, if they're very hypotensive, they may require fluids. You'd also want to check a 12-lead ECG to find out, either a 12-lead ECG or put them on a cardiac monitor to find out what their heart rhythm is doing at the time. So as mentioned previously, there is a wide range of differential diagnosis for palpitation, and if you find any adverse features, we need to treat the underlying cause. For example, if they are anemic or hypovolemic, then they would need IV fluids and possibly a blood transfusion. If they have a temperature and the diagnosis is suggestive of severe sepsis, they would need IV fluids, usually intravenous antibiotics, in order to treat that. If their ECG suggests a primary cardiac arrhythmia, then that may need treating straight away. If it's a narrow complex tachycardia, such as atrial fibrillation, atrial flutter, or supraventricular tachycardia, if they are hemodynamically compromised, they may need DC cardioversion. If it's a broad complex tachycardia, this can be a dangerous rhythm for the heart, and they would often require, again, DC cardioversion. Other options could include chemical cardioversion. I will talk about cardiac arrhythmias in another video. However, I just want to briefly mention narrow complex tachycardias, the acute assessment. So when a patient has a narrow complex tachycardia, it's sometimes often difficult to tell whether this is a sinus tachycardia, atrial fibrillation, some kind of supraventricular tachycardia like AV node reentrant tachycardia or AV reentrant tachycardia. One of the things we try to do at the bedside when patients are connected up to a monitor is to try and slow the heart rate down in order to try and reveal the rhythm. This can be done by vagal maneuvers or a carotid sinus massage. If vagal maneuvers or carotid sinus massage fails to reveal the arrhythmia, then adenosine can be administered intravenously with a flush. What adenosine does is it blocks the AV node and therefore prevents conduction through the AV node. If it's a sinus tachycardia or atrial fibrillation, then you may just get a slowing of the heart rhythm. If it's atrial flutter, then you will have the abolition of the QRS complexes and you'll just see the flutter waves. When the adenosine wears off after sort of 8 to 10 seconds, then the QRS complexes will come back. If it's a supraventricular tachycardia involving the AV node, then this can actually treat the arrhythmia and the patients can go back to sinus rhythm. So adenosine is very useful in these cases. However, adenosine does have some side effects when given, so you need to warn the patient. They may experience some flushing, chest tightness. They can induce bronchospasm, therefore adenosine should be avoided in asthmatics. An alternative to adenosine is intravenous verapamil. Also with adenosine, when administering it, you need to warn patients they can have the sensation of impending doom. So although adenosine is very useful, the side effects are there and you need to warn your patient about it. So in summary, palpitations are a very common presenting complaint to a cardiologist. The first thing you need to do with palpitations is to take a history in order to try and figure out whether the palpitation is due to a cardiac or non-cardiac cause. One of the initial investigations a cardiologist would use would be an ambulatory ECG, although there are other investigations which include the blood tests, a loop recorder or an exercise test. Once the cause of the underlying palpitation has been identified, then treatment can be specifically targeted to manage the underlying cause. I'd like to thank you for watching my video, and for future videos, please subscribe to be notified when they become available. Thank you.